You're live now, so you can start.
Can I start, sir? May I start?
Yes, Balaji, please
Yeah.
go ahead.
Good morning, everyone. I thank first Higgs to give this opportunity to present the hypothesis testing. Today we are going to see about the testing a hypothesis, and it's a part of the inferential statistics. And what do we intend to do in this session? My goal here is very simple, to make you less confused. As you know, statistics can feel overwhelming. When we go deeper into that, we try to forget all the concepts here. So I'm just going to demystify the key concepts and give you the practical tools rather than the theoretical rationale behind each test here. Definitely, we are neither trying to make you an expert in statistics or nor make you do statistical analysis in any software. It is just make us to understand the basic concepts here. As I said, I'm not going to discuss I'm not going to discuss about the complex mathematics and no statistical jargon. If at all, if you see any statistical jargon in upcoming slides, kindly pardon me. It is just for the better understanding of the concept here. So in this session, we are going to predominantly see four things. One is how to formulate a hypothesis and how to test the hypothesis. What are the tests available for the hypothesis? Second, what is the statistical significance of hypothesis? Third, confidence interval. What is confidence interval? What is the difference? And fourth, just a brief overview about the measures of central tendency and the dispersion. Many of you have overcome these slides in the prior webinars. I'm just taking 2 minutes for the quick overview. As we know, the epidemiological studies classified into two. One is a descriptive and analytical study. Analytical study where we do inferential statistics. The basic difference between these two groups are comparison. If the comparison group present, it comes analytical. If it is absent, it is just a descriptive study. In analytical, again, you have experimental and observational study. The difference here is if you have a prior comparator, if you have a prefixed comparator, or if you have a prefixed exposure in this group, it comes under experimental. The exposure can be anything. So it can be RCT. In observational, we have a cohort, prospective, retrospective, case control, cross-sectional. In this class, we are going to discuss more about this experimental section. How we are going to formulate a hypothesis, how to conduct a trial, and how to come to the conclusion based on the hypothesis. So this is where inferential statistics takes place. Inferential statistics, one of the frequentist approach. I will come to that later in the class. What is frequentist approach? So here we are going to formulate a hypothesis and we are going to see the significance and we'll see what is the estimation of the effect, what we got. And the last, to see the association or relation of the exposure to the outcome. So the idea of statistical inference starts from here. We have the whole population, but we can't do the study in the whole population. Of course we can do, but it's more time consuming and it's more demanding, technically more demanding, and needs a large manpower to conduct the trial. So what we do, we take a certain amount of the people from the population. This is what we call sample. Sampling, there are various types of sampling, not going into detail of that. Once we do the sampling, we formulate a hypothesis. What we want to do, what the physician wants to do. So what is hypothesis? It is just an educated guess based on our prior observations or existing knowledge. And we are going to check it on this sample. Then we'll get some value. We'll get some conclusion. Now, whether to accept it or reject it, that is based on the p-value or confidence interval. Once we get the data, we are going to extrapolate the same to the entire population here. So this is, in other terms, we call validity of the study, internal validity of the study. When we do the study in a particular hospital or particular region, and it should extrapolate the same patients, same populations. That is what called internal validity. So what are the statistical comparison we do normally in inferential statistics? We tend to do difference testing commonly. Difference testing, nothing but the comparison of events between the groups. Or you can see the treatment effect between the drug A and drug B in the outcome. Or simply we can monitor the patient outcomes between the groups. And we also can see association analysis between the exposure and the outcome, like smoking and the lung cancer. Or you want to see the higher driving pressure with the mortality. Then we see agreement, assessment of the agreement. Assessment of agreement is where we are going to do the test against the gold standard test, such as we are going to do the non-invasive cardiac output monitor with the pulmonary artery catheter, or glucometer versus a lab glucose reading, and we see the inter-observer reliability. So when do we need a formal testing? If you see the era between 1950s, the t-test was not so popular. Statistical significance are not popular. They just rely on the mean value. When they get the mean value or proportion, they directly compare it. Let's say the drug A gives a cure rate of 20% and the drug B shows a 80% cure rate. The choice is obvious here. But in a modern practice, in modern medicine, getting this significant value is highly impossible. So when we get the close difference, or when you know the significance is uncertain, you have an idea, but you don't know whether it has a real impact or not, we tend to do the hypothesis testing. So hypothesis, it is a basic, it is a foundation of the clinical trials. So every clinical trial begins with the assumption or a belief. Our job here is to prove or disprove the assumption through various statistical methods. This is what called a hypothesis testing. Understanding how hypotheses work is essential for interpreting study results correctly. So various steps in hypothesis testing. The first and foremost step is formulate a hypothesis. We formulate a null hypothesis and something called alternate hypothesis. And we should formulate something called a significant level. Before proceeding this trial, before starting the trial, we should determine what are the chances of error in the trials. Third is the distribution of the data. What I mean by distribution is whether our data is normally distributed or not. Fourth is after that analysis of the data using a particular test. And fifth is getting a p-value. Once we get the p-value and confidence interval, we have to make a decision. What is our decision? Whether to accept the hypothesis or reject the hypothesis. So before going into null and alternate, we can assume the hypothesis is related to our judicial system. So in a judicial system in the world's place, no one is guilty unless otherwise proved. The same thing happens here. So it is a prosecution liability to say that he committed the crime by showing the evidence. By showing the evidence, he's rejecting the possibility of not doing the crime. Simple. The same thing comes here. When we comes to the hypothesis, this is based on the Fisher model. Ronald Fisher is a statistician who created the null hypothesis system. So the null hypothesis acts, there is no difference between the two groups. When you are starting the study, the null hypothesis always states, assume there is no difference between the treatments. The alternate hypothesis says what researchers wants to prove, there is a difference exists, but we don't know what direction the difference is there. So in simple, what we believe is alternate hypothesis, what the statistician or the statistics believe is a null hypothesis. Here, the statistics works very simple. You got the data, you created a hypothesis, your role is very simple, whether to accept the null hypothesis or reject it. And we are not doing anything with the alternative hypothesis here. So here, the exposure usually is an independent variable. Usually, I mean, outcome is predominantly a dependent variable. So null hypothesis, there is no association between the exposure and the outcome. Alternative hypothesis is there is a exposure is associated with the outcome. So how we'll come to the conclusion? Simple. Do the test and find the p-value. At any time p-value is less than 0.05. You say reject the null hypothesis and say there is a exposure is associated with the outcome. You have to accept the alternative hypothesis. When we started the statistics as a clinician, we predominantly rely on this value. What we need when you got the data, just see whether the p-value is significant or not. Nothing more or nothing less. We'll see the flaws of this value in upcoming slides. Non-statistical terms of hypothesis. Sometimes when clinically we speak, we say our hypothesis is a simple hypothesis or complex hypothesis. Statistically, we will not mention like this. What is simple hypothesis? It is just increased, you are going to see the single variable, independent variable with the single dependent variable. For example, you want to see physical activity, increased physical activity with the cholesterol level. Simple. And the complex hypothesis is where you take two or more values with the two or more dependent variable. Let's say you want to see the effect of low fat diet or routine exercise with the risk of reduction, heart disease reduction and the cholesterol levels. So this is complex hypothesis. When it comes to statistical, it is not having much meaning actually. The moment we form the hypothesis, we have to label something called a critical region. It is very important here. What is critical region? As I said, the whole graph is accepting the hypothesis. This is a null hypothesis graph. The moment you formulate a study, you will get the graph which is a null hypothesis. Our job here is when to reject the null hypothesis. This whole area, 95% of the area, is where we have to accept the null hypothesis. At any point of time, your data stays less than 5% of this curve. Then we can say that is a rejection region. You can reject the null hypothesis. In other words, this is what we call significance level. Whenever we choose the date, whenever we choose a hypothesis, to minimize the errors, we choose something called a significance level. We'll see what are the errors in statistics in upcoming slides. So the moment we got this 5%, your data stays at the 5%, you can very well reject the null hypothesis. So what that 5% means? That means if I'm going to do the 20 times, if I'm going to do the same test 20 times, the odds of getting the same result is less 1 times comparing the hypothesis is true, null hypothesis is true. Or simple terms, it is by chance. If I'm going to do 20 times, only 1 time I get the same result by chance. Remaining 19 times, it is actually exists there. In alternate hypothesis, one thing I want to emphasize here is, when you create alternate hypothesis, you must have seen there are two things. One is the two-sided hypothesis or one-sided hypothesis. One-sided hypothesis where you know the drug effect, test drug effect. You are saying it is more than the control drug or less than the control drug. That is one-sided. Let's say your drug A is superior than the drug B or drug A is less than drug B. It is a one-sided hypothesis. When we know there is a difference exists, but we don't know what is the difference. It may be high or it may be low. Then it is a two-sided hypothesis. Why is it important? So important? As you can see the graph here, for one-sided hypothesis, we do something called one-tail test. Here the whole p-value, the whole 0.05 stays here. Instead of 2.5, 2.5, the 5% stays at the one part of the area. In the two-tail, it stays at the both tails here. So we are focusing on only one end. There is a chance we miss the other end here. That is the problem with the one-tail test. But is it really important to know the one test and two test? Yes. Why? You see here. So when it comes to two-tailed, we are testing the difference in either direction. It is predominantly used in the superiority studies when we don't know which treatment might be better. And it also detects both beneficial as well as the harmful effect. But in one-tailed, we are focused more on the only one side. So we are assuming the difference is existed there. We miss the unexpected events here, unexpected effects. We see with the practical feasibility. When you put the data in your SPSS and let's say you got the independent sample test, you are doing the t-test and you are getting a two value. One is a significant two-tailed value. Another one is will be significant, which is one-tailed value. You see the p-value here. One says it's 0.028. The another one says it's a 0.073 based on the F. So it is your clinician, it is a researcher job to say prior to the study, what is the statistical analysis we are going to do, whether it is a two-tailed or one-tailed. It will significantly affect the sample size. Let's say I did the one-tailed, but I took the two-tailed test, p-value. It is significant statistically. So I am misleading the research here. I am biased the research. So the methodology is not proper here. So it is essential to see whether we are using a one-tailed or two-tailed testing. Coming to the errors, the moment we formulate a hypothesis, the next thing comes to our mind is how to minimize the error. Errors are inevitable. In statistics, we can't avoid the error, but we can minimize it. There are two types of error in statistics, type 1 and type 2. Type 1 is false positive error, or which we know alpha error. So it says there is no difference, finding a difference when actually none exists. So it's a false positive reject. We are incorrectly rejecting the null hypothesis. Type 2 error, it is a beta error. And we are missing a real difference between the treatment. Actually, there is a difference, but our study missed the real differences here. So if both are actually goes in a reciprocal direction, if you are trying to minimize the one error here, the another error is automatically going to increase it. So our job is to minimize the both to the acceptable level. We can't completely eliminate it, but we have to come to the consensus of acceptable limits of error here. So in a statistical funny time, it's a hypothetical example. How we remember the type 1 and type 2? Let's say you're doing a sonography. Your sonography test says identifies male patient as a pregnant. It's a type 1 error. And the same sonography test missing the actual pregnant female patient. It is a type 2 error here. So what are the acceptable error rates in practice? We usually keep the alpha error rate as a 5%. So by keeping 5%, our confidence interval we are keeping 95. What is confidence interval? It is nothing but 1 minus alpha. If I am keeping it is a 10%, my confidence interval comes to 90%. If I am keeping it 1%, my confidence interval rises to 99%. So beta error, it is a maximum acceptable risk of missing real differences. So we usually keeps 10 to 20%. So when it comes to the study of the power, it comes 1 minus beta. So if beta error is 20, your power of the study comes to 80. So why can't I do alpha error of 1%, beta error of 10%, or power of 90%? Very well I can do. The only thing is it will increase my sample size significantly. And it is not practically feasible to do all the intervention with the same error rates. As I said, both goes in a reciprocal relationship. Our idea is, our goal is to balance both risk appropriately. Is an example, after formulating a hypothesis, keeping everything, I took example of Able study. How to formulate a null hypothesis? They formed a null hypothesis here. There is no mortality difference between the fresh RBC and the standard issue RBC. Alternative hypothesis, the mortality difference exists between fresh and standard. Remember, they just mentioned exist, but they didn't mention whether it is low or high. That means it's a two-sided hypothesis. So the alpha error also comes to two-sided here, 5%. It is very essential to calculate the sample size. The next, after that, what are the things to consider while choosing a hypothesis test? The most important thing is what is the type of outcome we are seeing, whether it is a dependent variable, continuous or categorical data. Continuous data we already know. Categorical data, whether it is a binomial data, yes or no. Next is the distribution of the outcome variable, whether the data is normally distributed or not. Third, number of groups in the independent variable. How many groups our study here, whether it is a 2 groups or more than 2 groups. Last, it's a type of data, whether we are having a paired data or unpaired data. It's repeated data or not repeated data, simple. I am not going to detail about the types of outcome variable. I just give a brief overview. Rather, I will directly go into the distribution of the outcome variable. Why is it so important? The moment you get the data, you directly can't jump into the statistical analysis. That's what Altman told. If your study not satisfying the normal distribution, you're not supposed to use the parametric method. It will falsely guide you and give a falsely significant result. So it is mandatory to see your data follows the normal distribution or skewed distribution here. So how will you identify what is meant by normal distribution? When you get all your data in the descriptive, and if you plot a histogram, your curve should follow the bell-shaped curve. Okay, and it should follow something called a 68, 95, 99 rule. This is what we call the normal bell-shaped curve. What is mean by 68, 95? When you form a curve and your mean stays at the center, and if you calculate the mean plus or minus standard deviation, one standard deviation, it should cover 68% of your data. If you take mean 2 standard deviation, it should cover 95.4% of your data. If your data satisfies these criteria, you can say your data is normally distributed. If it's not, it is a non-normal distribution. Why it is essential? We go with simple example here. I took a patient of 99 patients in ICU, and among 99, I have a 50 female patients and 49 male patients. My interest here is I am going to see the length of stay in ICU between females and the males. So when I get the distributive data, I got in the female patients a mean of 60 days. In the male patients, the mean comes to 30 days. There is a significant difference in the mean between female or male. Very well, I can say female patient stays more days in the ICU. Median was same, 31.5 and 30 days. Why there is a large difference? It is because of the data is not normally distributed. When the data is distributed normally, your mean should be equal to median and it should be equal to your mode. When you find a difference in mean and median, that means the data is not normally distributed. So why it is, if I am doing the parametric test, Assuming my data is normally distributed, directly I'm going to the t-test, my p-value comes somewhere around 0.04. I should accept it is statistically significant. So based on this p-value, very well I can say female patient stays more days in the ICU compared to the male patient. Is it so? No. We use the wrong test and the wrong parameter here. We supposed to use something called a non-parametric test. Instead of two sample, I should use something called a rank sum test. If I'm using it, the p-value comes 0.63. There is no significant difference at all. So choosing the right test is based on the distribution of the data. Now come to the thing. How will you see the distribution of the data? The common thing we see in statistics is central limit theorem caveat, where at any time your sample size goes more than 100 patients, very well you say the violations of the normality is very less. You no need to go to the normality test. But if you go for best practice recommendation, irrespective of the sample size, better to go for the normality testing. No need to rely on the sample size alone. The next quick method is what routinely we do in statistics is just see the mean and standard deviation. At any time, your standard deviation stays less than 50% of your mean. That's what we call CV method. If CV stays less than 50% of your mean, your data is considered normal. The only thing is you should have a minimum of 50 observations to do this test. If your observation is less than 50, you're not supposed to use this test here. Apart from normality, CV normality check, the conventional techniques for normality is, first one is the graphical method, second one is the statistical test. Graphical methods visually representing, easy to understand, but it needs experience to conclude. And it is more sensitive, especially when you have a low population or very high populations. So in graphs, we have a histogram, QQ plots, PP plots, and box plots. Not going into detail of this. And statistical test, we have a Shapiro-Wilk test and Kolmogorov-Smirnov test. We'll see that in next slides. Coming to the visual methods, as I said, the moment you follow your data, add for histogram, it should follow the bell-shaped same pattern. The measure should stay at the center and the both extremes should have equal levels. This is normal distribution. At any time, it goes towards one side, left skewed or right skewed. QQ plots are nothing but the quantile plots. When you get the quantile from the data, you will get the quantile. When you form the quantile data, it should follow the same diagonal line. If it's skewed to the one side, you can say the data is not normally distributed. Same goes to the box plot. The box plot has a mean and you have a standard deviation here. When the box moves to one side, particularly, it is not normally distributed. Visual methods easy, but it requires more experience to conclude it. Other test for normality is one is Shapiro-Wilk test and is KS test. Not going into detail, just simply when your sample size is less than 50, go for Shapiro-Wilk. When your sample size is more than 50, go for KS test. And in whole world of statistics, the only area where we will be happy if the p-value is more than 0.05 is here. The moment you do test, if your p-value comes more than 0.05, it indicates you have a normal distribution of the data. If p-value is less than 0.05, your data is non-normally distributed. Another few methods for the idea for the assessment of normality. One is a skewness and kurtosis. What is kurtosis? Kurtosis is nothing but the peakness of your distribution. Normally the peakness should go gradually bell-shaped. If anytime it goes very high, kurtosis, excess kurtosis of more than 3, that we call something called a leptokurtic, and it is flattened less than 0, you call platykurtic. Anytime it stays between -1 to +1, we say it is a normally distributed data. Not going into detail, most of the time we not use the kurtosis here. The normality is not complete if I am not mentioning the z-score. The z-score is the first test to identify the significance and the normality in old statistics model. Nowadays, we are not relying on the z-score here. What is z-score? The moment you get your kurtosis and skewness, and you just divide the kurtosis skewness by your error, standard error, you will get z value. So z-score is nothing but the k value divided by your standard error. So when the z-score is plus or minus 1.96, if the sample population is less than 50, it is normally distributed. If your sample is 50 to 300, your z-score comes 3.29 plus or minus 3.29, it is normal distribution. If it goes beyond that, it is non-normally distributed. So till now I confused with many tests of normal distribution. At the end, you rely on only two things. The moment you get data, ask for the histogram. And second, if your histogram is not satisfactory, go for KS test irrespective of your sample size. KF is Kolmogorov-Smirnov test for the normality. Now we know the data is normally distributed or not. Coming to the next important thing is choosing the right test. So before choosing the right test, you should give your data with the proper interpretation. So we have a measures of central tendency. We label the normal variable, continuous variables with the mean, median, or mode. When the data is normally distributed, you can say with mean, median, mode. It doesn't matter. When it is not normally distributed, prefer median. You can't mention it in a mean. That says the statistical error. We are not understanding your data. Coming to the dispersion, what is dispersion? How far it is away from your central value. That is what dispersion, simpler terms. So the dispersion commonly we measure standard deviation, quartiles can be interquartile range or the 25th, 75th quartile or coefficient CV and variance. If I am going to say mean should always accompany the standard deviation. If I am going to say median, it should accompany the interquartile range, Q1 minus Q3. If I am saying a mode, it can be variance or CV here. So after representation of appropriate data, we should choose a test. When it comes to the test, we have two types of test here. One is parametric, another one is non-parametric. The parametric data assumes the data is normally distributed. It is more powerful, less flexible. What is the meaning of less flexible here? Any missing data, few missing data will also affect this test significantly here. So we are not supposed to allow the missing data here. And it's suitable for continuous data and larger sample size. And here we are potentially using the central limit theorem. That means mean plus or minus standard deviation, bell-shaped curve here. And as I said, it is very sensitive to outliers. So common test are t-test, ANOVA. Coming to non-parametric test, it is predominantly used for the non-normal data or very small sample size, and it is robust to outliers, and it is more flexible but less powerful. Examples are U-test and rank test. When we consider non-parametric test, remember, if we are doing a research, we don't know how the distribution goes, but unfortunately we did our data came non-parametric distribution. We did the NP test here. What are the problems here? If you do NP test in a statistical world, it contains a low statistical power compared to the t-test. So it's smaller probability of detecting true association when the data is actually normal. And it requires a larger sample size for the same power. What is the meaning by this is, let's say you are doing a study with the 80% of the power. Your data is non-normally distributed. You did the analysis, you got the p-value. You can do something called post-power analysis. At the completion of your study, you can do post-power. If your post-power usually comes low when you do the NP test. So it needs a further study with a larger population. That is the idea of the NP test here. And another problem with the NP test is it uses a ranking system rather than the actual data value. Let's say I am doing a t-test and the rank test, and I am comparing the mean blood pressure between the two groups. The t-test says mean blood pressure was 5 millimeter lower. That means it is actually lower, 5 millimeter of mercury. But the rank test says 5, mean rank is 5. It doesn't mean it is 5 millimeter lower. It is a rank here. So the interpretation is little difficult. You can't directly say it is 5 millimeter lower. Coming to the essential part of the class, what test we have to choose and how to choose a test here. As I said, it depends on your variable, whether it is a data is normal distribution or non-normal distribution. And you are saying your data in mean or median, or your data is a dichotomous variable. And at groups, let's say you have two groups or more than two groups. So I want to compare the two groups and the data is unpaired. So two groups, comparing the mean between two groups, the choice of test is student t-test. I am comparing the median between two groups or non-distribution. It's a Mann-Whitney test. I am comparing the dichotomous variable or nominal data between two groups. It's a chi-square. So chi-square is uniform for the nominal data. Let's say I'm having a paired data. I have two groups, but in the same data is from the same groups. So you'll do paired test pre and post. For example, you are seeing an effect of hypertensives, antihypertensives pre and post, or sugar pre and post. So that is paired t-test. When it comes to the non-normal distribution data, you will see the Wilcoxon rank test. For dichotomous test, again, we'll go with the chi-square. McNemar is very rarely we use a McNemar unless there are specific conditions where the data we have is more than 2 cross 2, or we have more independent variables. Next is when we have more than two groups. So when you have more than two groups, you have a comparison of means, you have to go one way ANOVA. Let's say you have an adaptive trial, or you are doing effect of steroids in the 2, 3A, group A, group B, group C. So you have to see one way ANOVA. ANOVA is nothing but the analysis of variance here. When you have a non-parametric test, the same thing should be assessed by the Kruskal-Wallis test. And when it comes to the dichotomous variable, more than two groups, 2 cross 2, you do chi-square, but here is you have to do something called Yates correction. Chi-square is meant for 2 cross 2. When you have a population or groups of more than 2, you do something called Fisher exact or Yates correction of chi-square. Coming to the more than two groups, but we have a repeated data, we'll do something called repeated measures ANOVA here. For non-parametric, we do Friedman test. And this is the only area where we'll do Cochrane-Q test, where we have a more than two groups and the repeated data, we'll do instead of chi-square, we'll do Cochrane-Q test. So this one chart will tell all the tests required. I'm not going to detail of each test. Okay. So what will you do when your outcome as well as the exposure variables are quantitative variables? So when you have both exposure and outcome quantitative, let's say you want to see the effect of the mean airway pressure with the plateau pressure. Both is going to give a quantitative variables. So here we'll see something called a correlation between these two. So we follow the Pearson correlation. When the data is non-normal distributed, we will see the Spearman correlation. But simply remember, if both exposure and outcomes are quantitative variables or like a continuous data, you see correlation. When it comes to the association between the exposure and outcome, it again depends on whether your data is categorical or quantitative. Quantitative, very rarely we use nowadays, we see the beta coefficient. Coming to qualitative, let's say you want to see the effect of smoking with the cancer, or you want to see the effect of smoking with the mortality or heart disease. We see the logistic regression here. So the logistic regression will give odds ratio along with the confidence interval. It can be linear or univariate or multivariate, depends on the need. Cox regression is mainly for the hazard ratios. I'm not going to detail of all the tests. I'm just going to emphasize on the chi-square, which can be asked in the exams. Chi-square predominantly based on the Fisher model. This is a Fisher model chi-square test where we have a 2 cross 2 table. Exposure is your smoking. Outcome is a disease. So we have a null hypothesis where there is no association, and alternate hypothesis when there is association. The chi-square formula stays summation observed effect minus observed values minus expected values whole square divided by expected values. This is the only formula I want to emphasize because it may come in the exams chi-square test. So how will you calculate? This is the observed value. How will you calculate your expected value? So you have to take from the same table. So how will you calculate? You see here the observed value is 6, but the actual disease patient is 10. So we take the 10 and the total smoker is 100. And out of 200 patients, 100 patients are smoker, among 10 got the disease. So actually it should come expected disease of 5, but we got 6. Now we formulate another table, 2 cross 2 table. So we will follow, then we will calculate the chi-square test. The chi-square value is 0.1052. We correlate with the p-value from the table. This is the conventional chi-square technique. Nowadays, all the software has the inherent technique. We will not do all these things. Once we get the data, we just press the chi-square, it will give you the difference or p-value. Coming to the last part of this session today, p-value versus confidence interval. Both are not contradictory. Both should be used together rather than the individual basis. What p-value says actually? In convention, if p-value is less than 0.05, what do you understand by that? That means there is a less than 1% chance, 1 in 20 chance that your observed difference is arose by random. This is what conventionally. So it says statistically significant. As I said, it means if I'm going to do the test 20 times, the chance of getting the same result by odds by when the hypothesis is true, null hypothesis is true, is 1 time, less than 1 time. So when it comes less than 0.01, that means it goes 1 in 100 chance. So it is going stronger evidence against the null hypothesis. It is a simple value. What is the problem with the p-value? It is a single value. It just says whether to accept the null hypothesis or reject the null hypothesis. It is not going to say anything about your actual data or alternate hypothesis. That is the problem with the p-value. And p-value is limited by multiple factors such as effect size. Larger the effect size produces smaller p-value. So what happens is it may not be clinically significant. For example, you are doing a study in 5,000 patients with the antihypertensive drug. Your systolic BP drops by 5 millimeter of mercury. That 5 millimeter of mercury may be statistically significant. But is it clinically significant? That's the problem here. So p-value is significantly affected by the effect size. And the sample size, larger sample size. As I mentioned earlier, the larger the sample, smaller the p-value. The significance may exist or may not exist, but increasing the sample will make p-value significant. Next is variation. When your data has a larger variation within the data or between the groups, you tend to get the larger p-values. So you accidentally will reject the p-values here. So this is what we call p-value crisis. It started in the past 2 decades. Some journals actually banned the p-values outright due to the widespread misunderstanding of their meaning. The common misconception here is, remember, p-value is not the probability that the null hypothesis is true. P-value says probability of getting the same data if the null hypothesis were true. So what happened is we actually flipping the conditional. We confuse the probability of data given hypothesis with the probability of hypothesis given data. So it is actually reverse. The p-value says your probability of getting the data when the hypothesis is actually true. That's all. So why this thing started? It is all started from the Ronald Fisher. When Ronald Fisher started the p-value, he created the t-test and it changed the whole statistics model compared to the F model. So what happened is he kept the 0.05 based on the convenience. It is not based on the mathematical model, but it was followed all along till now. And it is an arbitrary value. So what p-value actually means is the data compatibility with the null hypothesis. Smaller the p-value, your data is compatible with the null hypothesis. It is not the actual proof of the real effect, and it is nothing to do with your alternate hypothesis. So what comes to the problem here is the smaller sample actually miss the effect. When you have a small sample size, there may be difference, but if sample size is low, you are not able to find the difference. So p-value will come high, you will reject it. So what happens because of that? Many trials which has a low p-value not getting published or they are not sending for publication. It leads to the publication bias. This is what we call the p-value crisis. The next p-value crisis is there are a lot of software came into the picture which manipulate the data for p-value. That is what we call p-hacking softwares. So data fudging here, that also happened to show p-value is less than 0.05. To overcome this, we use the 95% confidence interval. What is mean by confidence interval? That means I am confident my data 95% of the time will stay within this range. If I'm going to repeat the test 100 times, 95% of the time the data stays between this range. For example, I am getting an odds ratio of 3.12 in a smoker with lung cancer. If I'm going to do 100 times, the data 95% times will stay between these 1.1 to 4.75. It will not cross the limit. That is what odds ratio. That is what the confidence interval. It is not only says the significance, it is also says the magnitude and precision of the effect. And it also says the direction of the effect. The effect can be a positive effect or a negative effect. That also can be measured by the confidence interval. So this is another example of confidence interval. Let's say I am seeing a prevalence of anemia in the antenatal mother. My prevalence came 70%. My confidence interval came 65 to 75. How will I interpret? I am 95% confident that prevalence of anemia in antenatal mother stays between 65 to 75%. That is what the inference of confidence interval. As I said, p-value test only one null hypothesis. Confidence interval takes all the hypotheses consistent with the data. And it is actually calculated from the data, from the actual observation, rather than the p-value, which is the theoretical observation. We just keep a p-value of 0.05. That's all. It is not from the data. So when you mix, when you club the together p-value as well as the confidence interval, the yield increases. So this graph you can see, this is a 0, which is no effect, and this is 1, where we call the line of no significance actually. At any time the p-value is less than 0.05, you say it is statistically significant. And confidence interval goes below the 0. That means it is a reversed effect. You did the study to identify the positive effect, but your study showed it is a reversed effect. That is what the inference here. Anytime the p-value or confidence interval cross these two lines, you can simply say it is inconclusive or neither statistically or nor clinically significant result here. When you have a p-value of less than 0.05, many of the times we get the result. When it is less than 0.05, but you get the confidence interval stays at the level of 1. Let's say your odds ratio crossed 1 or your risk ratio crossed 1, confidence interval. Then it is statistically significant, but not necessarily it is clinically significant effect. That is what confidence interval says here. When both are actually p-values less than 0.05 and your confidence interval comes to the positive side beyond the line of no significance, this is statistically and clinically significant effect. In a researcher world, everyone wants this effect. So this is what again leads to the publication bias and data fudging here. So one hypothetical example, can we get a p-value of less than 0.05 but confidence interval stays between 0.94 to 2.8? That means it crosses 0. Is it possible? No. If your data shows this, that means there is a significant errors in your data or calculation or interpretation. You have to recheck your data because this is based on the assumption. When your p-value less than 0.05, you are rejecting the confidence interval. Confidence interval should be more than 1 or it should be more than 1 or less than 1. Not necessarily should be a 0. It should not cross the 0 here. So that's the problem here. So you will not get this kind of data. If you get in studies, please recheck your data. So in final, p-value and confidence interval. P-value is to test the observed effect is likely due to chance. Simple. Confidence interval is to estimate the plausible range of effect size. How far the effect size is there. Whether narrow the effect size, higher the significance. Output is a single probability value and the confidence interval come the range of value. P-value is a binary decision, just tells significant or non-significant. Confidence interval will tell three things. What is the effect size? What is the direction? What is the precision of the estimate? P-value is a qualitative and the confidence interval is a quantitative interpretation. Among all this, till now, whatever we saw, it is called a frequentist approach. The problem of hypothesis testing with the frequentist approach is these two, how to interpret these two. Sometimes you have a data which is clinically significant, but statistically it is not significant. Can you reject the data or can you stop the study? No, you can still extend your study based on the Bayesian statistics. Bayesian statistics is beyond the scope of this class. We'll discuss some other time. I'm just going to tell three things. When you form a Bayesian statistics, you will have a two probability. One is before concluding the study, before conducting study, your prior probability. After conducting study, how your probability changed. That is posterior probability. Based on these two, we calculate something called data, BF data or likelihood ratio. That is what we call BF factor. If BF factor comes 1, same like a odds ratio, 1 line of no significance, that means there is no change. At any time the BF factor goes more than 10, it has a strong evidence your data is clinically significant. If it is more than 100, there is a decisive evidence like a data is significant. So Bayesian statistics is coming into the future. It is slowly overcoming the mixed with the frequentist approach. So key takeaways, at the end of the class, I know majority of people will be like in this state, confused state. Although I limited my jargons like a statistical jargon, but it's still inevitable here. So first thing is choose the appropriate test. It may be statistically significant or clinically significant. How will you come to judgment? That remains essential. And you should know limitation of the p-values and don't stop your test based on the hypothesis testing alone. Try to extend the test based on the Bayesian as well as the effect size. Thank you.
Thank you, Balaji.
Yes, sir.
I know, sometimes statistics can be very, very boring,
Yes, sir.
and sometimes it can be a little confusing.
Yes, sir.
But the way you have taken it, with clarity and minimizing the lot of statistical jargon, but
Yes, sir.
giving an idea about what to look and where to look.
Look, yes, sir.
It was kind of a revision for me as well.
Yes, sir.
Though I'm going to go back and listen to the lecture again,
Yes, sir.
because I think for many of us, when we look at any paper, we blindly go with whether the p-value is less than 0.05.
Yes, sir.
In fact, that is what when you hear people talking about, when giving lectures, when they want to quote a study,
Yes, sir.
they always highlight that the p-value is less than 0.05, p-value is less than 0.05 without actually understanding the pluses and minuses of that.
Yes, sir.
Right.
True, sir.
Thank you very much, Balaji.
Thank you, sir.
And it's a really very, very simplified way of understanding how to test a hypothesis. Before actually looking at p-value,
Yes, sir.
you also have to look at a lot of other things.
Yes, sir. That's true.
That's it. Thank you so much. And if there are any doubts, please do let us know. We will get back to you with the solution. Thank you, Balaji. Thank you very much.
Thank you, sir. Thank you so much, sir.
It was really a pleasure listening to you.
Thank you, sir. Visual, sir.
Thank you.